initiative. It is our last webinar of this year of the joint initiative. So welcome to all. Today we have Dr. Kadir, and we have a very special session on research trends in neuro-urology. So it is very special session because it gives you the perspective of the future of the neuro-urology. And for me personally, as I am very much interested in research, I believe that research is gives the new perspective, and it is the future of our young students. So it was very special for me. So I hope you all liked it. So with this short introduction, I invite Professor Kadir to have a floor.
Okay. First of all, I want, can you see my screen now?
Yes, Professor.
Yes.
Is that okay?
Yes, it's okay.
Okay. First of all, I want to thank you, Medsynergy, INUS, and Ruth, and also Jalesh for give us this opportunity for this educational summer. In this presentation, we are gonna talk about the exciting development in neuro-urology, and we will talk about a little bit future and ongoing studies. I must confess that I am glad to talk about this topic right now, since this paper published in 2015 complained the poor evaluation of research in new treatment modalities over the last 20 years. Obviously, this have reinforced the strength of the evidence for some treatments, such as botulinum toxin A, but at the same time, this has given to us the awareness that we need more treatment for the following reasons. And as for antimuscarinics, also approximately 40% of the patients after botulinum toxin E discontinue treatment over the time. As you can see, the botulinum toxin treatment is the next step treatment modality in patients with neurogenic detrusor overactivity resistant to antimuscarinic treatments. As you can see, we endoscopically injected the botulinum toxin A into the bladder, detrusor muscle, or submucosa for 100 or 200 or also 300 units. As you can see, as a meta-analysis or review articles, after the botulinum toxin injection in neurogenic lower urinary tract dysfunction, incontinence resolved almost up to 73% of the patients. Capacity is increased almost 80%, and detrusor pressure is almost 40% of the detrusor pressure is decreased. And by the way, just after the botulinum toxin injection, urinary tract infection can be seen almost 40%, but in the long term, when we look at the long-term results in this kind of patients, the recurrent urinary tract infections episode is significantly decreased after botulinum toxin injection. One possible explanation is the high risk for starting intermittent catheterization in MS, multiple sclerosis neurogenic lower urinary tract patients. Here, because the proposal of decrease of dosage of botulinum toxin E in patients unwilling to perform intermittent catheterization. So nowadays we can apply the 100 unit instead of the 200 units in patients with detrusor overactivity due to the neurogenic lower urinary tract dysfunction. Or the considering neurogenic disorder activity, beta-3 adrenergic such as a mirabegron or the newest drug vibegron, which perhaps could be higher tolerant, but despite their safety and efficacy, one concern is the cost of this drug, which is not covered by the NHS of neurological people neither. Actually, beta-3 agonist is not well working as a anti-muscarinic drugs such as a drugs blockage M2 or M3. Beta-3 agonist is not a standard treatment for the neurogenic disorder overactivity now. Considering the bladder management, we know that our patients, our neurogenic patients, are at the high risk to develop urinary tract infection. And we know that the problem of antibiotic resistance is all over the world. As you can see, the upper urinary tract dilatation can cause from the high bladder pressure, detrusor sphincter dyssynergy, fibrosis in the detrusor muscle, and also infection, as you can see. We can see here, maybe I can use a laser pointer here. The small bladder, small neurogenic, small bladder for due to the neurogenic lower urinary tract dysfunction, these patients have high-grade bilateral reflux here. You can see the kidney collecting system. You can see the contrast medium into the left renal collecting system here. We can call it the high-grade reflux. And among these different strategies of non-antibiotic oral or intravesical prophylaxis proposed to reduce the overuse of antibiotics. Currently, the use of bacteriophage seems to the most promising, especially in patients with neurogenic lower urinary tract dysfunction, who often need clean intermittent catheterization. A bacteriophage solution could easily be instilled in and used for acute or recurrent or also chronic urinary tract infection. There's a missing slide here. To avoid catheterization and catheter-associated urinary tract infection, of course, we know that one method also in neurogenic bladder is the unobstruction and reduce the urethral resistance, mainly due to the sphincteric dyssynergy in spinal cord patients. Regarding that, there are some anecdotal publications about the use of lasers, but not comparison have been yet made between old and safe techniques, succession by pioneeristic authors more than 45 years ago, and laser sphincterotomy. Instead, laser is much helpful in treatment of the stones, both for upper urinary tract and lower urinary tract, as reported in this study. Laser seems samely effect in treatment also of bladder stones larger than 3 centimeters compared to open technique with less complication. We can usually use laser or pneumatic lithotripsy in bladder stones. In this study, demonstrated the bladder stones treatment with laser is so has good results. Robotic techniques have been introduced to minimize surgical morbidity, as you know. Thus, this is an unstable, not standard yet. Why the first experiences in neuro-urology have been done in children for bladder augmentation. Preliminary study regarding the functional outcomes of after robot-assisted intracorporeal bladder augmentations in adults are really promising. In the future, we hope that this technique will be widely applied. But till now, the only comparative data regarding the safety reported a similar rate of perioperative complications, and there is no superiority when compared to open technique in robotic techniques. With the steadily increasing popularity of robotics, this approach has been also recently proposed for artificial urinary sphincter implantation in female patients. As you know, we put artificial urinary sphincter in patients with stress urinary incontinence, and stress urinary incontinence can causing also neurogenic reasons. Besides the surgical technique, indeed the cost effectiveness, functional results, and impact of the quality of life in female patients with neurogenic stress urinary incontinence should be still determined. Sometimes we put the as you know artificial urinary sphincter in also male patients. We have several technical differences in artificial urinary sphincters, such as a mechanical or hydraulic systems. As you can see the left side here, fully circulating hydraulic systems, such as a Victo or another one, and you can see the mechanical or electromechanical or also magnetic sphincter. We have an anal sphincter, magnetic anal sphincter, but we don't have yet magnetic urinary sphincter. Hydraulic sphincter, as you can see at the storage phase, the cylinder or the cup is open, as you see. You can see the mechanical sphincter at the right side. Some development came out in regard with sphincter, such as electromechanical sphincter. We usually use just a hydraulic system with manual system. What we can electronic or electromechanical engineering. This system can work sometimes high pressure, sometimes low pressure. For example, if the patient is sleeping with at the bed in the laying position, the system is automatically decrease the pressure at the cuff in order to prevent the erosion of the urethra. And that means we can program in this kind of the electromechanical sphincters. There were several ongoing studies with these sphincters around the worldwide, especially in Europe. Of course, another option is in neurogenic bladder, currently limited to very selected neurogenical patients, is neuromodulation. Over the last few years, the system has been very smartly evolved to better active treatment adherence with the higher attention to the need or radiosurgery of battery replacement. But which are the real potential of the neuromodulation that we need to investigate in the next future? The high-tech futures, I think that our expectation must be other, and what make the differences must be functional outcomes and not only the technological aspect. To make an example, nice shoes do not always fit very well. To date, all systems are open loop, which means that there is no input and real time from the body. We need a dynamic adaptive conditional system which can stimulate or inhibit the neural signals to restore the micturition function. And this is possible if we have a feedback from body to system. For instance, sensory of the bladder wall pressure, like in this experimental study. One sensory monitor the bladder contraction. As you can see, there are many attempts to find the better sensory feedback from the bladder. But other indirect feedback decoding the signal from the detrusor can be also detected on the all of the neural pathway involving the micturition or urination. Also, okay. Such in this very recent publication, which closed-loop system was developed using neural responding from dorsal root ganglia as a sensory feedback. As you know, the sensory feedback from the bladder goes from the dorsal root ganglia, and the motor response goes from the anterior root from the spinal cord. So acquisition of the signals can be done by decoding or directly measuring, and the modality of stimulating can be several and not only electrical. It could be chemical agents, infrared lights, optogenetics, such as visible lights, and also ultrasonic pulses. This is a model of closed-loop wireless system using optogenetics. When the bladder becomes overactive, the signal is sent to the small inorganic LEDs, which in turn activates a light-sensitive protein, an opsin, to selectively reduce the neural activity. There was some new neurostimulator, such as the amber pudendal stimulator, is placed at the trunk of the anterior pudendal nerve, and also get some feedback from the external anal sphincter and pelvic floor, and embedded patient's actuated tab, we can call the accelerometer. The tab induces the activation of the some nerves, and this activation can provide the more additional time to reach to the toilet to patients. As you can see, some in this kind of neuromodulations can decrease the mixed urinary incontinence, and also significantly decrease of the urge urinary incontinence in clinical settings. Picostim is another neurostimulator. Picostim system can use Parkinson's-like multiple system atrophy, and it is also under investigation now. And they concluded there are several emerging treatments in preventing rather than treating neurogenic lower urinary tract dysfunction, such as a spinal bifida newborn. This is a protocol for early management and treatment with the antimuscarinics and intermittent catheterization in spina bifida newborns to avoid complications such as a deterioration of the upper urinary tract dysfunction. And again, there are several causal treatments to cure primary neurogenical illness, such as anti-NOGO antibodies to treat spinal cord injury, which are under investigation also, and which can have positive effects on preventing neurogenic lower urinary tract dysfunction. Or this study to investigate effectiveness of the effectiveness of an early remodeling of the neural circuits using no invasive neuromodulation, such as a sacral neuromodulation or pseudo-antenna neuromodulation and others. This is a percutaneous or transcutaneous posterior tibial nerve stimulation. This could be promising for acute phase of the neurogenic lower urinary tract dysfunction due to the spinal cord injury. This is our new techniques to introduce or to put the neuromodulation lead into the S3 foramen. This method, in this method, we use a brain lab system, navigation system, in order to detect the spatial system. Where is the S3 foramen is where at the real time. At first, okay. At first, we put the patients on the table. As you can see, we put the reference tool attached to the table, and then patient's fixation on the table. We can fix the patients on the table with bands, and then before we get the tomography images from, and we record to navigation system, and then we mark with some special pointer some special points onto the patients, and this machine, brain system lab machine, is registering the patients is where regarding according to this reference tool. And then we can also attach to the another pointer into the foramen at the foramen needle, and we can see where is the needle, where is the needle goes, and we can also see the trajectory line which we target the S3. We can see the real time. This is a navigation assisted neuromodulation as a new techniques. We defined these techniques, I think, 4 years ago. You can see the foramen needle here. The brain lab system can detect where is the foramen needle, and if you want to do advanced, if you when you advance to the needle, you can see here the red line trajectory line here. We, as you can see, we aim at the S3 foramen. Almost with 1 or 2 millimeter error, we can also 100% introduce or advance the quadripolar leads to which we aim to foramen, sacral foramina. And then also nowadays, at the maybe last 5 years, the stem cell applications came out in the clinical settings. In studies, maybe Dr. Jalesh Paniker, he is as a neurologist. We know that if the patient has spinal cord injury, and we can inject the stem cells on the lesion size above or below, or also lesions, there's no statistically significant differences regarding to the dead pressure or bladder capacity or voiding efficacy. There's no changes after the this stem cell therapy at the site of the spinal cord injury. And we have some tissue engineering treatments, such as scaffold-based approaches or cell-based approaches. Dr. Limin Lo from China use the small intestine mucosa in order to augment the neurogenic bladders, and we can say they augment the 8 patients and capacity increase almost for 170 ml to 380 ml, and compliance is also, as you can see, increase almost 6 or 7 folds, and also detrusor pressure is going down after the augmentation. It's the first human studies, as you can see. There was a new treatments we called the TAC 302 to promote the neural growth. This study examined the effect of the TAC 302 in underactive bladder. As you can see, if in this study, overactive bladder, but did not divide the subgroups as a disease type. And there is a little bit significant increase the detrusor pressure. There was another study, muscarinic 3 receptor allosteric modulator can also promising treatment modalities in detrusor underactivity patients. Another randomized controlled trace is electrostimulation and also extracorporeal shockwave therapy onto the bladder. If we can stimulate the bladder, according to some studies, there is no significant differences in regard with voiding efficiency, but another studies can also suggest and also demonstrate the extracorporeal wave therapy, shockwave therapy can increase the voiding efficacy. Optogenetics integrated expandable electronics and optogenetic complex that behaves a single body with the elastic time dynamic urinary bladder with substantial volume changed to up to 300%. The system configuration of the electronics validated by the theoretical model allows to conformal seamless integration onto the urinary bladder. As you can see, if our video can works here, as you can see, this magnetic system can also initiate the bladder contraction during the micturition and provide the efficacy micturition. But this study is under investigation now. Also, we can try the stem cells in our clinical trials. Actually, stem cells is not working very well at the spinal cord injury. If we injected the stem cells at the injury sites, but in detrusor overactivity, if we do inject the autolog muscle derivated cells into the bladder detrusor muscle can start to do working again, can cause and you can see in this study stem cell therapy can cause increase in voiding efficiency over the time. After cell therapy, almost 77% of the patients not need the clean intermittent catheterization and stop the clean intermittent catheterization. This is another new therapy, Önem Condit. We defined this technique almost 7 years ago. We can use this technique for obtain a longer conduit, which the patients need to use in during the augmentation. And if the patients wants to do clean intermittent catheterization, as you can see, some patients with wheelchair dependent patients need to do clean intermittent catheterization more higher level. Almost they need to do CIC at the level of the umbilicus, because there is difficulties. They have difficulties to reach their native urethra, and so especially in adult wheelchair and also obese patients, this is difficult to reach their native urethra and need to do a more longer channel or conduit to put the umbilical event, and we defined these techniques. Yes, we have a annual congress at the Yogyakarta in Yogyakarta in Indonesia, and I want to invite you if you want to join us at Indonesia. Okay, I want to thank you for your interest, and I think we can get a questions, Abhinav, now. And if you have any contribution, Ruth and Jalesh, I appreciate your contribution. If you have, thank you.
So, if anyone have questions, they were invited. Raise your hands with Professor Kadir or from any professor. Raise your hand or write in the chat.
Yes, Ruth.
Ruth, yeah, please.
Maybe I start with a question. I think all those, there are so many points where I think that could be really change the world of spinal cord injured or neurogenic patients. One field which interests me is the direct stimulation of the afferent nerves, as it was done in the Brindley stimulator or the FinTech stimulator. I've seen patients who were very happy. So just for you who don't know the procedure, it is an active stimulation of the afferent nerves, but in order so that it works, and that is the drawback, all the afferent nerves from the sacral micturition center were cut. So then the patients are safe from detrusor overactivity, and they can void or also even empty their bowels and have erections by direct stimulation of the afferent nerves. Now the whole procedure is now, due to regulation limits and that FinTech kind of is sold, is still a way, I think, which would be very good for the future, but what would be much better if we wouldn't have to cut the afferent nerves, but if we could stimulate or destimulate the afferent nerves. It's like you said in this feedback model of your mouse or rat. I think, do you see any chances of doing exactly that? Cutting or blocking the afferents and stimulating the afferents.
Actually, Ruth, I have newer experiences with Brindley stimulator, but I wish, I hope in the near future, we want to put the Brindley stimulator. It is working very well, more than maybe, according to literature, 1,000 patients. As you told you, patients can starting to self-voiding and also erection and big bowel habits. So,
but it's the drawback is, first of all, you if you have any sensory left, they lose also the good sensory. I mean, it's not nice not to even feel your penis. So you have to be completely, you have to be a complete different. You have an ASIA. So otherwise, it's not. you wouldn't advise a patient to do that.
Yes.
But especially if you suffer from autonomic dysregulation and have anyhow lost all your sensory, then it is a good way. But it would be even better if you could do the same procedure, which now involves actually cutting all afferents and afferents. If you could do that also with stimulation.
Yes, it could be good to use another treatment modality instead of the dorsal root rhizotomy. Maybe we can stimulate the nerves with another way in order to blockage instead of the cut. Actually, I don't know. There is no stimulation method up to now to blockage the nerves. In clinical settings, we can try some neuromodulation, such as a pudendal, in order to wait more easy. But this kind of the patients is also there is no optimal stimulation hertz and voltage in neurostimulation, pudendal neurostimulation. We try to do change stimulation period, such as from 15 or 14 hertz to 50 hertz to fatigue the nerves in order to not stimulate the pelvic floor. But actually this doesn't work very well. In Berntley stimulator, maybe near the future, there is a new method to blockage the dorsal roots instead of the cutting. And we can use maybe more number of patients.
Professor Delish wants to say something. Professor Delish.
Well, I was just going to add, I mean, there are research protocols where they are exploring high frequency stimulation.
Yes.
So in place of having to cut the nerve root. So it's the dorsal rhizotomy, but my understanding is that they haven't been successful yet, but it's ongoing research.
Yes, right.
Can I ask one question though about the very high frequency stimulation? You know, like the 1,000 hertz stimulation for pudental with pudental nerve stimulation. You know, in regards to relaxing the sphincter, the external urethral sphincter that I think you briefly just touched upon. But you know, and for DSD, do you see promise in that? This is really, of course, the work is really being pioneered by the Pittsburgh group. And Chris Szymanski has been involved, is leading on a trial, eventually just a proof of concept in spinal cord injury, essentially to see if very, very high frequency of 1,000 hertz can interfere with the neural pathways and result in sphincter relaxation. Do you see a future in that?
Actually, in regard, in point of my view, maybe, I hope, with different electrostimulation, we can provide that.
Because currently it's a very physical approach, isn't it? You have DSD, either it can be there can be a sphincterotomy, which of course is not at all sort of promoted nowadays, or you could try a chemodegeneration through botulinum toxin, or possibly once again mechanical, something like a stent. But that's really about it. There's whereas neuromodulation would be a much more sophisticated way of going about it, but of course it is very early days.
Maybe in future we can provide that with stimulation of the inhibitor interneurons in the spinal cord, for example.
Thanks, Professor. There are some questions in chats. Can you see, or I will read out?
Okay, is there any question, Abhinav?
Yes, Professor Kadir, there is some questions in the chat. Will I read out? Or you can see?
Okay.
Okay, I will read out.
I can read here. Okay, okay. From Maso Sorin, do you have any thoughts on early CNM after surgery? Yes, there is a preliminary results after the sacral neuromodulation in early period of the spinal cord injury, and these studies demonstrated that the preventive features of the sacral neuromodulation in early spinal cord injury patients. And the second question is, what is your opinion on bladder neck periurethral stem cell therapy injection for stress urinary incontinence? Actually, there's a ongoing studies in animal studies. There is a promising results in stem cell therapies at the injection of the external sphincter, urinary sphincter, can increase the sphincteric pressure in order to prevent stress urinary incontinence, and we need to do more human studies up to now. Another question is to prevent overactive bladder and keep the bladder as underactive, low pressure. Is that a question? I'm not sure. To prevent overactive bladder and keep the bladder underactive, low pressure. I think Masul Korean. What did you mean, Masul? Can you clarify your question, please, if possible?
Okay.
Oh, okay.
Okay,
Thank you very much for this information. We have a 6th-year medical student in Turkey from Turkey, Esra Demir. Esra Demir, which university you are now? I wonder that. Okay, thank you.
Okay. Professor Ruth wants to say something.
Yeah, I think we have to, we now speak a lot of sacral modulation and different types of modulation, but we have to make clear that in a complete SCI lesion, we can't modulate the nerves, because if there is no action, the nerves can't be modulated. At least this is so far as we understand now. And as far as I stand, I think doing stimulation in this spinal shock phase has been tried, as far as I know, by Kadir Önem in Germany. But up to now, I haven't seen anybody jumping on that train. And it would be so easy, and because sacral modulation in different types is so much introduced in nearly all neuro-urology centers, that if nobody can repeat these first successes, I'm a little bit skeptical. And I think we need a profound scientific question and to have a study clearly designed to answer a question before it is, just introduced as a hope therapy, because we have patients, no guinea pigs.
Okay, Ruth, do you think the photo time now?
Okay.
Yes.
Okay. Photo time.
So before that, before going to the fight, I will sum up for the 6 weeks. Okay.
Always in the end, we ask to put your cameras on.
Yeah. So first of all, thank you, Professor. With this today's final webinar, we are completing our 6-week course. So on the behalf of whole my team, I sincerely want to thank INUS and especially Professor Ru and Professor Zelish for their continuous guidance and encouragement. This course is possible only due to you. So thank you so much. And also to all the professors and speakers who were sharing your expertise and inspired us throughout. And also, I'm very glad thanks to Miss Parvati also for bringing her continuous effort in participating, bringing the continuous intention survey. And so I also invite everyone to, I will send the link after this webinar. So take part in that survey. And also to thanks to all the participants for your dedication and curiosity. I say thank you and for your active engagement, at least. This course was only success due to you only. So with this conclusion, thank you to all of you. And
but also thanks to you,
we look forward to
Avinash.
continue.
And also thanks to you, because with all your technical support, and I love your constant reminders and your links, they are so easy to use. I think, Dalish, you agree, that made it a really wonderful experience. And Dalish, and I would really recommend, look into INUS, go at the website, and if you're under 34, I think, or under 35, you can join for free. And doesn't mean you have to come to Dr. Carter. Of course, we are happy for everyone who's coming, and we need you as a young doctors or physicians of the future to, we kind of deal with the niche patients, but they are important, and worldwide there are lots of unmet needs, not only in Ukraine, but I think also in other countries with few resources. So, and it's a fun group to work in.
And if I could
Yeah,
just
yeah.
add there, I mean, I think it's been incredibly impressive that Abhinav, you and Christina, that you've got this Medsynergy group amongst medical students in a very challenging part of the world, and bringing such numbers of medical students, and practitioners and scientists. Actually, there are scientists on this call as well, from not just the Ukraine, but from around the world. Even at the 6th week of the course, I think is amazing. And it just goes to show how this has been organized. Plus, I would concur with Ruth. I mean, the content shared has been fantastic. And we've ended on such an inspirational note with Kadir this afternoon. I hope the message has been conveyed to everyone who's attended these sessions that neuro-urology is not a niche, exotic field. It's something that you will come across in your day-to-day practice if you become a neurologist, if you become a urologist, a rehabilitation specialist, a geriatrician, a surgeon, across which the disciplines, neurogenic bladder is something that you will come across, and having a firm grounding that will actually make you a specialist with I suppose an added layer of specialization. That's what we hope to achieve with this. And I think Ruth, Kadir, and I would actually wish all of you all the very best in terms of where you take this knowledge. Specifically to the group in the Ukraine, is really, and particularly Ruth's interest, is how to develop neuro-urology at a practical level in terms of Ukraine. We hope that this is actually a springboard for that as well, or part of an ongoing journey to Ruth as well.
Yeah, thanks. I really appreciate it, and I will try to translate the speeches in Ukrainian, and then kind of repeat it also for those who are not so firm in English.
Yeah, we do.
If I may add, Abhinav,
Miss
can I
Pavarti,
add
yes,
something?
Miss Pavarti.
Yeah,
Yes,
hi.
please,
This is yeah. Sorry, I'm not in a position to turn the video on because the network connectivity where I'm sitting isn't great. So apologies if my voice gets broken in between. So thank you all, wonderful doctors and professors who have worked today with us, Kadir and Ruth, and all the other doctors and professors who joined the course in the last 5 weeks. Thank you all so much, and the wonderful participants who have been so cooperative all this time. And thank you again, once again, to Abhinav and Christina. I just can't tell my thank you loud enough, because they have been so proactive for all the 6 weeks in forwarding the link, reminding the participants about the study, the survey before the course, the survey after the course, and for the interview participants. You have been so wonderful. You have been just wonderful people in arranging the online course, and the participants participants have got such wonderful feedback, which I will obviously I will share with you in a few weeks time, and they've been really cooperative. So well done to all the participants for their patience and their dedication for all the 6 weeks. Thank you once again, Abhinav and Christina.
Thank you, Ms. Parvati. Thank you. Unfortunately, Christina can't able to join. She is in another event right now. So yeah. Okay. But thank you from her side also. Thank you to all of the professor, and thank you once again to all of you.
For all participants for your interest in neuro-urology.
Yeah, and it will continue. I hope it will continue to remain so. Okay, so now I ask everyone to open your cameras. Finally, our photo shoot session. Open your cameras. I can't see that now. Yeah, now I can see.
Oh, yeah. There are more coming. Oh, that's okay. If somebody has no camera, that's also okay.
Yeah.
So, did you make your photo?
Yeah. Say hi. I hope that
Okay.
next time also, next year also, we will see each other.
Yes.
Yeah.
I'm kind of optimistic that we also find a way to continue this program.
Great.
You're
So,
all welcome.
thank you. Professor Jalesh, yeah, I can see now.
Thank you, everyone.
Yeah. So, okay, thank you so much to everyone. Okay, thank you.
Okay.
Have a good evening, and you will soon receive the link for today's quiz and also for the survey.
Have a nice day, everyone. Thank you so much.
Lovely being. Bye.
Thank
Bye,
you.
everyone.
Thank you.
Kadir.
Thank you wherever you are.
Bye.
Thank you, Professor
And
Jalesh.
peace.
Thank you. Bye-bye.
Okay,
And thank
bye.
you, Professor.
Bye.
Goodbye.